Today I'm super psyched because we're going to be having a conversation with David or Dr. David Perlmutter. He's the Executive Vice Chancellor for Washington University and also the Dean of the School of Medicine there. And he's also, you actively run a laboratory. So you are really in the trenches. And may I say, you're the only person on any Zoom meeting in the last month that's been wearing a necktie. And you've done this now three times
Should I
in a
take
row.
it off?
No, 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 no. I want you to keep it on. It's just that I have Fed meetings where they're not wearing neckties, right? Like
What does that
you
say,
represent
Jim?
the high mark in
What does that say?
in meeting decorum. And I know you're super busy, David.
Yeah.
So, but I just, we had such a great conversation over the last couple weeks. You inspired me to take some action. And I thought it would be good I feel really lucky because I get this inside information from the Federal Reserve, which makes me feel, a certain way about the economy. And I wanted to share that.
Right.
But now I've got a little bit of insight about what's happening in the people who are going to save us, which is the medical community. And you're in a fantastic spot to give insight. So I appreciate your time today. And first question, because we predicted, or you told me that the prediction was that this was going to be the peak of the infection in St. Louis. Have we hit that peak, and have we exceeded the capacity of the hospital system here?
Yeah, we're close. I think this week will probably be the worst of this phase. We have had very slow increases over the last 10 days. And while that occurs, you can see the smoothing out of the curve when you model it compared to other cities and other countries. And actually, when you look at what happens with this virus in the other countries and in the other cities, what you can see that there are some that are early, some that are later, some that have had more difficulty smoothing out the curve. The ones that seem to have been the most effective at smoothing out the curve, Seattle, San Francisco, we are looking like them.
So St. Louis, Missouri, has done something. Do we know what we did, or is it just sort of luck? We don't know why.
Well, it's
Sort of
pretty
antisocial
clear. It's pretty clearly
yeah.
the public health interventions, the staying at home, the preventing of large groups of people meeting, so really it's the public health interventions that have led to the smoothing out of this curve. It is clearly right now within the capacity of this hospital system, which is about 35% of the market share.
So you're with
clearly
BJC
within
hospitals, and that's about a third of St. Louis's total hospital capacity
correct.
That you're part of.
Correct.
Okay.
And we as in Washington University is partners with BJC Healthcare. We primarily take care of the academic hospitals, and so we take probably the biggest chunk of all the ICU care in the St. Louis metropolitan area. And this has clearly been something we've been able to handle now. And we say that with perspective of inpatients, intensive care unit, ventilators. We did struggle with personal protective equipment, but right now we are stable in that area. And we've been working very closely with the other hospital systems, the city and the county and the state, on managing all aspects of this problem. This is an all-in, everybody has to be working together.
Okay.
The big changes that we made to handle the surge were to reduce all elective surgeries, all elective clinics, and all inpatient admissions that were not absolutely necessary. So the hospital system is actually working at about a 40% occupancy, all of which is to preserve hospital beds and equipment for a potential surge. And we haven't even occupied that surge capacity to date.
Okay, so it's not as if you've ramped up your capacity and could just maintain this. You've gotten this excess capacity by essentially shutting down all the other stuff that you were doing
Correct.
that was serving patients and also supporting the hospital.
Correct.
So another way
Financial.
of putting that is that you used to make money doing hospital business and you're now no longer
We
making
are
that money.
we are hemorrhaging money.
Okay, so a lot of people have this idea that this is a boon for the hospital, sort of like it's a boon for Amazon. Yes, you're busy, but you're not busy in the ways that make you money. You're busy in this emergency response that paradoxically is really hurting the hospital financially.
Right. And it shows you how cash dependent hospital operations are. They're massive amounts of cash that come from the ordinary patient care, and that amplifies the problem.
So has the federal government stepped in and said, look, you guys are critical. We're going to give you this
We
infusion
have
of money?
we have already received payments from the federal government, but they're relatively minor compared to the damage.
Okay, so what percentage?
I would say about 5 to 10% of the
Holy
damage.
shit. So like you lost $20 and they gave you $1 back
Yes.
and probably made you fill out a bunch of forms to get it.
Yeah. Now we're still early in this, so
Okay.
just to
Is
give you
it
an
a,
example, and this stuff is coming out now. The School of Medicine is losing about 50 million a month. BJC is losing about 150 million per month.
wow.
Yeah.
So collectively 200 million a month. Okay.
So the irony of this situation, Jim, is we have faculty and staff, physicians and nurses and staff who are risking their lives to take care of the community at with enormous financial consequences. And yes, the Federal Relief Act has provided us with some money, but as I mentioned, it's between 5 and 10% of the hit.
Is this true for hospitals across the nation, or
Yes.
is this just we got unlucky here because we're a big
No.
research hospital?
No. This is happening across the country. Interestingly, the outlier is New York, where the hospitals are full of coronavirus patients. And of course, they're going to be paid for those. So
Oh,
to a
so if
certain
we had more
extent,
coronavirus patients, then you could bill. But since we're just ready for a lot of coronavirus patients
correct.
and stopped all the normal business, okay, so it's a financial train wreck.
Yes.
Okay. Well, so but not to be all gloomy here. It's not like you're shutting down. It's that things are tight, but the hospital is still people are still coming
Yes.
to work and still doing the work they need to do.
Yes.
Okay.
So
Um,
we're feeling the same thing financially that everybody else is feeling.
okay.
And uh, and but part of our purpose in our profession is to step up to the challenge. One of the other things that's important to mention is that we're, in addition to reducing the volume of the cases, we are also seeing much better outcomes for the patients who end up in the intensive care unit. So,
So can I get that as a percentage of likelihood if I show up in your hospital if I'm going to leave in a body bag?
well, it's if you just took it as percent of inpatients who expire, inpatients with coronavirus that expire, it's about in the neighborhood of 18%.
Okay.
Now, what had been recorded elsewhere were things like 70%. That's
70%. And
quite a
is
bit
that a
different.
third world statistic, or is that 70% in other?
That was what we heard coming out of China and Korea and et cetera. That if you got into the now, what I don't know is the number for if you got on a ventilator, what would your survival be? But my my overall point, without getting into the details, is the survival for severely affected coronavirus patients is better than we had heard earlier in this crisis. And that
So,
could be, I think many of us believe that has to do with how good our intensive care units are.
okay. So do you believe Washington U's medical system or BJC's medical system has some trick that other hospitals don't know, or just it's
I
just general
don't know
confidence?
that yet. We don't know that yet, but um, we're really impressed by how good our patients have done, relatively speaking. Doesn't mean that we've had 29 deaths. Now, I don't know all the 29, but many of them are much older people and people who are with significant comorbidities. So even that number is probably not a bad number given the what we had heard about the severity of the disease.
Okay, so Washington U, BJC, and St. Louis are doing pretty well.
Yes,
If you got to go to a hospital, this is a pretty good place to go to a hospital.
yes, absolutely.
So let's talk about some of the proactive things you're doing. You reached out to a group of us last week, or I guess 2 weeks ago, and said, "Hey, we've got some really promising uh, investment opportunities." Well, I shouldn't say investment because we're not going to get our money back. uh, you asked us to give you money to fund activities that could lead us to either a mouse model so that we can test vaccines, or a vaccine itself, or a test so that we could all get out in the world and know if we're healthy or not. Um, and you made the pitch that it was important for private money to come in and do this, um, partially for speed, but perhaps for some other reasons. And I'd like you to just sort of quickly explain how that works, because to me, it sounds like the small amount of money that I gave you was trivial compared to the amount of money that the system itself is losing. I mean, it's like 1% of what you're losing. So how could that even matter? Um,
So the funding is essential for us to accelerate what these groups are doing. So the groups, what what I said to the group was, number one, we want to provide acceleration and urgency to what I would describe as a Manhattan Project for us to try to get some solutions for this problem as soon as we possibly can. Not only because it will have an impact on the community here, but an impact on the economy of the world by doing this. And then also, it's part of our obligation in leveraging the resources we have. It's a very, very interesting time in my business because we describe ourselves as academic medicine. I think of that as two things. First, we know that 5% of all the hospitals in the United States are what we call major teaching hospitals. Barnes Jewish and St. Louis Children's Hospitals are major teaching hospitals. That kind of hospital is only 5% of the total, yet we take care of 31% of the indigent population. So we are the I describe it as the safety net for the United States.
so
And
let me
secondly,
translate that for a second, David. Is it fair to say that the people who don't really have health care officially still get health care unofficially through organizations like yours?
correct.
Okay.
And those are the patients who have significantly complicated and significant sickness and vulnerability disproportionate to the rest of the population. And the virus is actually showing us that. And so that's one of our purposes. Our second purpose, which we believe distinguishes us in academic medicine, is that we're committed to doing research to improve on the outcomes for tomorrow. And that's where we have an obligation to leverage our assets to try to solve the problem, no more urgent than this problem. And so, so I asked the group to help me accelerate that. We know that we can also apply for NIH and federal funding.
So when you say the group, this is a group of rich guys, right?
Correct.
Yeah.
You
It was,
said it, not me. I, I, I pulled together a group of people who had the wherewithal to help us accelerate this on behalf of the St. Louis community.
okay.
And this, and I consider this to be heroic work. So what do we believe we can do? First, the first, and I would add, you mentioned three, I would add a fourth, but let's start off with the animal model. We will be the first place where where there are animal models, high throughput animal models for testing every aspect of this problem. Testing vaccine candidates, testing of drug candidates, including drugs that are already approved by the FDA that can be repurposed for coronavirus, drugs which are late in the pipeline of FDA approval, which could be more rapidly moved into potential intervention for coronavirus patients. And and then also potential antibody therapies. That's called passive immunization. All of those can be tested in this mouse in a way that the rest of the world doesn't have the ability to do the kind of preclinical testing.
So what I'm hearing is there are a bunch of drugs that we want to test and a bunch of therapies we want to test, and we would rather test these on a little mouse than on my next door neighbor.
Because
And
it'll be more effective and eventually it'll be more time effective, it'll be more efficient, and then presumably, and then their testing in humans subsequently will be safer.
okay, so if we test these cures or therapies on mice, we'll learn more faster, and fewer people will die. Um, and how is it that Washington University's the only place that's going to have this mouse ready in time? Like, what's so special about the
Well,
mice?
it's a combination of having the expertise to having gotten the virus early.
Oh, so wait a
Uh,
second. You started working on coronavirus back in January.
Correct.
Ha ha. How did you know to do that? Why didn't
Well,
the rest of the
we
world
have
do
an
it?
insider here, Mike Diamond, and this is similar to the story, Jim, of Zika virus. Mike knew about the Zika virus, I think about 4 or 5 months before it was even put in the news. And and in that case, he actually had the Zika virus in his freezer. In this case, he had to get some information from China, but he had the virus early, so he was able to infect the mice early. And all of this work, by the way, goes on in a biosafety level 3 and 4 facility, which we are one of a few places that have that kind of facility. And
So we got a
and
jump start on the
yeah,
whole thing,
right.
and we're partially too developing a mouse, or did we then prioritize the mouse when we saw how bad the actual outbreak
This
was?
was what had been used before for the Zika virus epidemic. The same approach was used. And so
Okay,
we had already had experience doing this with a different kind of virus, but with a kind of virus.
so the net of that is that WashU's likely to come out with a mouse that allows the world to test. So this would be the mouse they test in Italy. We're going to is there going to be a big
This
uh,
will be exported to other laboratories for their use as well. And
okay.
they will be testing done here, and and our and we believe this is the kind of testing that gives you a much more sound basis for anything that you do in human trials. We're in an era where there's so many trials being done in a way as fishing expeditions.
Okay, so if you had the time, you'd do it this way. But I guess my question would be, global pandemic where people are dying anyway, isn't it like, those experimental cancer drugs where it's like, well, the FDA hasn't really approved it, but we're going to sit here and shoot you up with Laetrile and hope for the best.
That's absolutely true, um, but if you want to bet on what's likely to get there sooner, it's something that's worked in a preclinical trial. So,
Okay.
yeah, I'm not objecting. In fact, we're doing trials in humans um, in a way where you take the shortcuts that you want to take. Now, you don't want to take a shortcut that you believe might be even worse for patients, but you do take shortcuts if you're weighing out the risk and the benefit in this situation that you wouldn't take ordinarily.
Right.
And so, but but as we look at and we won't do as extensive preclinical testing as we would ordinarily do either. So this will be the words will be quick and dirty, relatively speaking. Um, but already Mike has tested in this mouse a potential therapeutic antibody, a therapeutic antibody that was developed here.
So in addition to having a mouse, we have a potential therapy for this.
Correct.
And that's the second thing you're testing.
And so that's the second big innovation that's happened here. We have identified an antibody.
What are the odds of that working?
I don't know. I don't know how to describe that. They're all long shots. If you really, they're
Yeah.
all long shots, and ordinarily this kind of work would take a long time. I mean, I was noticing somebody saying that the whole idea that you would have a vaccine in 18 to 24 months is very optimistic. That in some cases, vaccines have taken 3 or 4 or even 10 years when a particular infection has occurred. But in any case, yeah, I don't know. I don't know how to describe what the likelihood of the antibody is. The way we look at it at this point is we're going to try to accelerate it as fast as we can, which includes both um, expanding the funding to these investigators so that they can test as quickly as possible, giving them more personnel, and already beginning to develop the industry partnerships that would be necessary to produce the antibody at scale. We would need to produce it at industrial scale. I lost you. You're muted. You're muted.
Sorry, David. I had
Yeah.
a stupid phone call coming in, but
All
hopefully
right.
Bill could just mute.
Yeah.
Since I wasn't talking there, it doesn't really matter.
Okay.
All right. Sorry about that. My phone now rings on my computer, which is annoying on a number of levels. Um, okay. Well, this is so So we have a mouse that will allow us to then test a vaccine or a therapy. We have a therapy that we're testing, although who knows if the odds of that working. Um, the other thing that's super exciting is that Washington University has a potential to come up with an antibody test. Is that
Yes.
so? What's the difference between an antibody test and that swab they stuck up my nose 2 weeks ago?
So the swab is for detecting the virus. So
Okay.
the swab tells you, do you have the virus or not?
Okay. So you could have the virus and then recover from it, and then you don't have the virus. Is that
Correct. Then
is it?
and so the virus is evidence that you are acutely infected.
Okay.
And the antibodies presumably tell you that you had it before.
So, for instance, I was sick a month ago and I don't know what it was, and I didn't get tested. So, I don't know if I've had it or not. And because there's no good antibody test right now, I don't know if it's safe for me to go out. Is that a fair
Correct.
characterization? And if I could take an antibody test, would I want it to be positive or negative?
You would want it to be positive.
Okay, so I would want to have already had this
Yes.
and be one of the cases where it was a minor case, and then I can go get back out in the world.
Although, honestly, we don't know yet how protective any antibody would be. But if the virus is like many, many other viruses, now I'm talking like Tony Fauci, if the virus is like many other viruses, more than likely what's called the IgG antibody will be evidence of protection. How protective? Um, it'll take quite a while before we really understand these things in detail. What we're hoping for is a point of care, high throughput, scaled to be able to screen many, many people that we can use to reemerge, critical to reemergence.
Reemerge as a society. In other
Right.
words, we don't want to just take the systems that have been protecting us for the last month or month and a half and abandon them and say, well, we flattened the curve. Now everybody go
Right.
back out and
We
start
want
bugging.
to try to reemerge in an intelligent way. And we, as you hear all the time on the news, we want to be able to use phasing and testing and tracing of contacts in order to make this happen in a way that doesn't produce another surge.
Okay. So if we had that information, then presumably we could have some sort of safe zones where only people who are safe can congregate. Is that how you
Yeah.
imagining
Or
it?
go back to work. Any of the measures that we took would be okay if everybody had immunity.
Okay.
And also we need to understand how many people have immunity in order to make the right decisions.
How far away are we from a viable test, either yours or one of the 90 others that I've heard of in the last week?
Now we're working both on an antibody test and a better viral detection test. So we believe if we can do both things in the community in a screening fashion, so it's scalable to large populations, that we will even be better off because then we have both sides of the equation. The current viral detection, which is what is talked about in the news, has problems. Firstly, it is done with the nasopharyngeal swabs that are short in supply, and it is
That's that
done
painful
with,
thing that's this long that goes up my
and,
nose.
and it's very painful.
Okay.
And secondly, it's done with a PCR machine and cartridges for those machines that are limited in supply. And that's what all the crazy stuff on the news is about. And that is true. So what we are doing at WashU is we are developing point of care, high throughput, scalable assays, both for viral detection and for serology, antibody testing, that are not dependent on any of those reagents. The premise being that we could use that for St. Louis.
So would I have to go into my physician, or could this be done at
We
Walgreens?
would imagine, well, I think hopefully we would begin to think about executing on that in multiple locations, but we're
Okay.
not really there yet.
All right. How close to being there are we? I mean, if we
We
can do
have
this
some
testing, we
we
probably
have some,
open the world.
and by the way, these are being developed with saliva. So we have some pretty exciting news. I think, and the FDA rules, by the way, are that you can get with a relatively minimal uh, regulatory requirements, you can get up and running for 90 days before you have to submit really hardcore validation. So it's possible we could do this in the next couple months.
So, in other words, there's no theoretical um, impediment to that happening in the next couple of months. We just
Yes,
have to have a lot of
we
smart people
need to
doing the work.
validate. We need
Yeah.
to validate now. Right now, we're in the process of validating two assays. Um, the second part of the challenge will be how do we get it into a high throughput, scalable form?
Sure.
And we're imagining that that's going to require some partnership with industry.
But I
And
would
then,
imagine
of
industry would be
course,
all over it because they make a ton of money, right?
yes, there should be interested parties. We're just beginning to explore that in the same. And then the third thing, which is ongoing coincidentally, and I think this involves the hospital system, all the hospital systems and the governments and the public health departments, is standing up screening sites. We have some that we have used. In particular, we've set up screening sites for our healthcare workforce. But the city and the county will need to set these up for all of the population, and so those things can go on now and should be going on now.
So, David, my next call is with a pretty high level government official. And what would you want to tell them if you could get out a quick message
It's
to that
really
person?
important. It's really important for them to be focused on the public health part of this equation. It's amazing, Jim, how public health is so important. Amazing because we actually know in the history of our society that the major improvement in health and longevity has been from public health, not from medicines per se or treating diseases.
Would you define public health, please, for those who are
So,
not?
public health meaning all of those things that control that allow us to have clean water, food, regulation of regulatory compliance of the food, shelter, the basics of having a healthy environment. All of those things have had a much bigger impact on health and longevity than medicines or medical care. Um, so here, public health is the isolation of cases, contact tracing to isolate other cases, and and preventing the spread of the virus. And so the most important thing for our government partners, the city government and the county partner government, when we're talking about the St. Louis metropolitan area, is for them to be focused on the public health interventions that are going to be needed. And I would describe them, I would break them down into screening sites, um, having the amazingly, you're going to be amazed, the informatic infrastructure to trace cases, and
Sure.
then to implement the measures of executing on isolation where needed. And we will also need to focus on the areas of the hotspots, which, as you know, are the nursing homes and elderly residences and the poor neighborhoods. And all of those things fall in the realm of the public health department. Here in St. Louis, Washington University and BJC are collaborating, as are the other hospital systems, are collaborating. And we are actually, here we have the public health expertise, the public health science expertise in the Institute of Public Health, in the medical school, in the Brown School. We've been doing all the modeling. We are working with the county on their informatic infrastructure. Um, and the amazing story of this country is that the public health departments of the cities have been decimated. They
Okay,
don't
so
have the assets to do this.
what you're saying is that we used to have a public health system that was reasonably robust. We don't now. And the fact that we don't is one of the reasons we have such a health crisis right now. And one of the reasons the
Absolutely.
economy is shut down.
The testing and the implementation of public health measures.
Okay. So if I were to ask you the question that everybody is starting to ask now, which is, when do we get to lift this crisis? Assume you've got antibody testing coming out in 60 days, which is probably the most, June 1, we get a decent antibody test that's can be
Right.
performed without fancy equipment in doctor's offices or maybe even in a Walmart. And you, as somebody who gets to see both from a researcher and from a physician and from a guy who's intimately involved in the hospital system in a major city, when do you think we're going to go back out?
Well, I think, Jim, and this is a sensitive part of um, that you and Dylan may want to edit. I think we're going to have to come out before we have all the tools. I think the reality is, because the economic impact is so um, significant, we're going to have to start to phase in our reemergence before we have all of the components. The feds did come down with an outline of phasing, which I think we all think is a pretty reasonable thing. I don't know, a pretty reasonable proposal. I don't know if you've seen it, but it in essence says if you've had 14 days of negative trajectory, you could start into phase one. And of course, it says if you have adequate testing and if you have
Blah blah blah.
adequate contact tracing, and of course they don't define that.
Of course not.
And so
Neither.
And so the reality is, Jim, that we did this first part without adequate testing. And so you make decisions And by the way, we live in a world, a clinical world, where we never have the ideal scenario. So you make decisions based on perhaps not ideal conditions. And I think that's where we are right now. I think that is what we believe is going to be part of our leadership on this also, helping to get things going in as intelligent a way as we can while we're actively developing better systems.
Okay, so I mean, this is a
So
problem.
I'm thinking end of May, beginning June, we start to see some initial phases.
End of May, beginning June. By the way, this is a problem that is not unfamiliar to entrepreneurs or people who are building new products, which is you always know the product can be better, but you're going to ship it. And believe me, I've shipped some products that I knew
It's
had
called
a ways to
flying by the
go.
seat of your pants.
Well, yeah, you are in a situation where time is an enemy, and I think your statement on public health was really telling because if you said to me that the basics are what makes more difference than some gee whiz medical application, the basics are really being hurt right now,
Yeah.
and we may be losing more people to the economy than to the virus. And here's a physician on the inside saying probably we will reopen before we are medically optimal, but it's not the only variable in the equation. Well,
Yeah, and I'm nervous about that because I think that people like me should be saying what's medically right.
well, I think you have, and I think you're also a person and a father and a neighbor, and you're seeing what's going on. And look, we all want to make the best decisions. And but the beautiful thing is, you also have the medical perspective, which I
Yeah.
never had, and I wanted to share it with people. So,
Yeah.
Dr. Perlmutter, thank you so much for
Thank you,
taking the
Jim.
time today, and
It was fun to talk to you.
hopefully this will maybe comfort some people. So,
Yeah.
thanks again.
Okay, Jim. Good to talk to you.